And then hopefully that was a good demo for you guys and got some good discussion points on that. I'm going to give you another chance to watch a little bit of an overview with your proctors as well of the opiate abuse. So I'll pause for a minute for that. She does a good job, I think, of talking through some of the really important concerns with opiate abuse and withdrawal management. Because even though we don't classify it really as one of the deadly things, the potential fallout with, diarrhea and nausea, vomiting, and the dehydration, it can, even though the pain component of it might not necessarily be the lethality part, there, uncontrolled withdrawal or abrupt withdrawal can be very, very serious as well. So with our opiates, we have opium, which is from the poppy plant itself. We have opiate, which is derived from the opium, and we have opioids, which is the synthetic morphine-like actions, but it's not derived directly from the poppy plant because it is manufactured. So there's all different kinds of forms and shapes of things. Not that everyone needs to be an expert on what all these drugs look like, but we have the prescription type things are oxycodone, hydromorphone, morphine. We have down there at the bottom methadone. We have different types of heroin. This is the black tar. We have brown powder, white powder. This little thing next to the penny here at the bottom, this is fentanyl, and that's actually a lethal dose of fentanyl, those little white crystals. And you can see it in this slide, but I'm going to show you the next slide why this is like the sort of cautionary tale for nurses as well. Lethal doses are getting smaller and smaller. So here's your lethal dose of fentanyl, or heroin, excuse me. Here's your lethal dose of fentanyl, and then we even have carfentanil, and there's some other synthetic opioids out there, and you probably can't even see the difference in here on these baggies. There's tiny little crystal, and on your screen, you're probably not even going to see it. So why do I bring it up? This is, I know we preach about hand hygiene and putting your gloves on and all of the things, but why both our patients and sometimes even our staff are at increasing risk in terms of the potential lethality is that some of these, you can't even see the difference. So if it's mixed in with something, or like they've cut fentanyl in with somebody's methamphetamine or put it in the marijuana or something, even the people that are doing it may not be precise enough to be able to differentiate what would be something that they could actually get high on or something that's going to kill them. So we are seeing, again, with the opiate epidemic, just many, many more people at risk for unintentional withdrawals or unintentional overdoses, excuse me. So with the intoxication itself, what are we expecting? What are we thinking we're going to see? So that small pupil, except with Demerol, because it causes the paralysis, you see that pupillary constriction, that kind of nodding off, or it's like we call them sort of the narc nod. They just are continually sort of almost losing consciousness. You can see that hypotension, slower respiratory rate, bradycardia, everything. I mean, everything's slowing down. The central nervous system slowing down. But the mood, the report can be like a euphoria or kind of a floating feeling, that get kind of loopy on you. So if we're looking at early and middle and late withdrawal, what might we see? So the early withdrawal, you're going to see eyes watering, like lots of yawning, which you may notice that's on the COW scale. Runny nose, so again, really kind of leaking out a bit, sweating, and mood-wise, that sensation of anxiety or doom, like I feel like I'm going to die kind of thing, high anxiety as they are in early withdrawal. In that middle phase, they get really kind of it's hard to sleep. They get very restless. So if they're sleeping, it's in short little bursts. The pupils will go the other way as they're starting to withdraw. They'll dilate. They have no appetite. You can see the pular erectus, so the goosebumps kind of thing. Very irritable. And then in this middle phase, you can start to see a tremor develop for some folks. As we get into later withdrawal, it's all of these other earlier symptoms, but the blood pressure, heart rate starts going up. And they get just explosive nausea, vomiting, diarrhea. And y'all are nurses, so you know what I mean by explosive. It is pronounced. And that's really the risk around dehydration in this later stage. The mood can get very, very labile, everything from irritability to agitation to depression. And they can begin to experience like muscle spasms or like weakness. They'll often describe it as like the worst flu they've ever had. It's like bone deep kind of pain. So what's the time frame? So for our short-acting opiates, the heroin, fentanyl kind of metabolize. The half-life's about 2 or 3 hours for heroin. So the onset of the withdrawal after the last dose is right around 8 hours to like a day, kind of depends. There's still some variation in terms of how people metabolize it. So once it's, kind of hitting that 8 to 10 hour mark, that's probably when you might start seeing those early withdrawal symptoms. If they're only using the short acting, the duration for the withdrawal, the whole course of it, early, middle, late, the whole course would be about 5 to 10 days. So 10 days being at the long end of that. But long acting, if they're on something like a methadone, the half-life can vary. It is, again, all over the map, anywhere from like 8 hours to almost 60 hours. The average is around a day, around 24 hours. So when we're looking at onset of withdrawal, can be anywhere from that like day to like 2 days, right? If they're coming off of it and going off altogether, the duration of the whole withdrawal, meaning early, middle, end, will be on the far end of it about 20 days. So it is very uncomfortable for a very long time if they're abruptly withdrawing. The opiate receptors that they're looking at, again, the mu gets activated by the morphine. That's what gives us that analgesic effect. It mitigates the pain receptors in the brain, but it's a primary action site of all of the opiates. But it also does things like the CNS suppression and the slowing down of the GI tract. There's, the kappa ones, again, have some analgesia, some endocrine change. This is what we think leads to a lot of the dysphoria that can be pretty prevalent in withdrawals. Why do they get so depressed? These sort of kappa receptors are a little out of whack. And then the delta ones for the androgenous peptides. So the withdrawal scale itself, and again, I know this is probably going to be small on your screens, but we're going to make sure that you get these as handouts. We're going to walk through it as well. But the opiate withdrawal scale does address things including heart rate, their pulse, again, I just said it, but the GI, the sweating, tremors, restlessness, yawning, pupil size, anxiety and irritability, and then the pain, like joint pain, the goose flush, and then the runny nose, and then it'll give you a score totaled. So your proctors, as they're going to go through, are going to give you a little overview of the cows. So I'm going to pause for a minute